Okay, dear students, and now we've reached one of the main milestones of our academic case history, which is preliminary diagnosis. Your manual, it says that preliminary diagnosis is based on results of history taking physical examination only. Yes, that's right. It represents generalized assumption about possible disease and should be brief, example, peptic ulcer or diabetes mellitus. But let's discuss this point a little more, because that's going to be very important. Before writing the preliminary diagnosis, let's see what we already have. So first, we have patient's passport part. From this part we know his age, gender, and some information about his family and place where he lives, but that's not very relevant. Next, what we've already obtained are patient's complaints. Among patient's complaints, we've discriminated main complaints, in our cases we are discussing a case of acute appendicitis. They are pain in a right iliac region. Next, while describing where this pain came from and how it began, we know that this pain occurred about 6 hours ago. It started at the epigastric region. Then it migrated to right iliac or inguinal region. That's what we already know from the first part about gathering complaints. Other thing which we know about secondary complaints, we know that a patient has mild hyperthermia, he has a subfebrile temperature, we know from his words that he's not feeling well in general, so he has general weakness. He might also experience nausea and other certain secondary symptoms. You may just think of it by yourselves, but still that's what we know. Next, what we also know from previous part of the case history, we know his life anamnesis, the anamnesis vitae. we know that this patient, for example, he never was admitted to a hospital previously. He tells us that he didn't have any surgeries or some severe traumas. He can't tell you something precisely about chronic diseases which he experienced throughout his life. We've asked him about his close relatives, like parents, brothers, sisters, maybe grandparents, and he has no signs of some genetic diseases. And finally, we've asked him if he's not allergic to some drugs or foods. So his allergic anamnesis is not compromised. These are just very brief points on what you've already discussed within the first part of case history. When you will write your own, you'll have to write this part more. You'll have to provide more information on patient's complaints and anamnesis. Well, after that we've gathered his complaints, we've collected his anamnesis of present disease, his anamnesis of life, his allergic anamnesis, we proceed to physical examination. Our physical examination was built by organs and systems. You will have to describe briefly what's wrong about some system or some organ of some system. For example, you might point out that his blood pressure is increased, or that he has some specific sound in his lungs. Doesn't matter, but in general, if you don't find any pathology, you write still brief information as we've discussed, and you summarize it that clinically he has no signs of pathology because, well, like this. For example, breathing system. You write the conclusion that he has no clinical signs of pathology. And then you describe why. Because his breath is vesicular, because he has normal limits of his lungs, because you don't hear some abnormal sounds during percussion or during auscultation, and this leads you to this conclusion you've made that among respiratory organs, he has no clinical signs of pathology. But let's emphasize on where he has pathology. We found out that he has increased basic temperature, this temperature is, for example, 37.2 degrees Celsius. Next, we've found some pathologic signs during examining his digestive system. We found out that during superficial palpation, there is pain and tenderness in the patient's right iliac region. We've also found out that in this region also he experiences the muscular defense during deep palpation. We've also found out that he experiences pain beside that. We've found out that in similar area he has positive symptoms of peritoneal irritation. Although we've discussed only one symptom, it's Bloomberg's symptom. You should know that appendicitis has a very vast majority of peritoneal irritation symptoms. To my notice, up to date, it's not for your case history, it's just for you, because you're going to learn a bit more about acute appendicitis to write more precise case history. So as far as I know, up to date, there are 118 symptoms which are directly related to acute appendicitis, and among them nearly half are symptoms of peritoneal irritation. So we've discussed only one very specific and very pathognomonic symptom which occurs in a very large number of patients, but one is not enough. You'll have to do some extended reading, and you should write down at least 2-3 symptoms more. Which are related to acute appendicitis. Once again, there are more than 100 described symptoms of appendicitis. That's why there will be absolutely no problem for you to find additional 2 or 3. Okay, so let us continue then. Besides that, we found positive peritoneal symptoms. During further discussion, we've found out that this patient has, for example, frequent stool, two or three times per day. This is mostly liquid. That's another very familiar symptom of appendicitis. It doesn't occur in a lot of patients, but if it is present, means that some part of small bowel or large bowel is in contact with inflamed part of the appendix, or it's in contact with the site of inflammation, and it is secondary irritated by this inflammatory site. That's why it results in increased peristalsis and increased stool. You may also point that out in your case history. Well, that's enough for symptoms we found during examination of gastrointestinal system. Digital rectal examination usually does not show any signs of specific pathology, but this is what you also have to point out in this part of in this part when you finalize describing the physical examination of gastrointestinal or digestive system, that during digital rectal examination you found no signs of clinical pathology, as we've previously discussed. But we've continued to examine patients' urinary system. You may also write down that this particular patient has frequent urination. Which is accompanied by small portions of urine output. This can also be a symptom related to acute appendicitis because when the site of inflammation, the inflammatory exudate migrates downwards to the pelvic cavity, it can irritate the parietal peritoneum, which covers the urinary bladder, and this may result in its excessive contractions, which is experienced by patient as additional mm, wish to urinate. It's similar to loosened stool, as we've previously mentioned. It doesn't happen all the time, but uh, it can be observed frequently in cases of destructive appendicitis when the inflammatory process already destroyed the appendix as an organ and it just turned into purulent, it turns out into just purulent. After urinary system, if a patient is a female, we can notice that during bimanual examination, the pain in a woman's right iliac region increases. This might be a very useful and very important clinical finding, which obviously must be reflected in the text of your case history. It will help us with differential diagnosis, which we're going to discuss a bit later. But if a patient is a male, we can find another symptom which is quite relevant to acute appendicitis. For example, during palpation of testicles and during examination of patient's inguinal canal, which also is a part of male's clinical examination of genital system, you may find out that he feels irradiation of pain. Or even more, he can feel not only irradiation, but during palpation of his inguinal canal, he may feel that the pain in right iliac region increases. This can also refer to acute appendicitis. The mechanism of this symptom is similar to frequent urination and loosened stool when pathologic effusion from destructive appendicitis irritates the parietal peritoneum, which covers the inguinal canal and the spermatic ducts. They also can be irritated, and when we palpate in the inguinal region, or when we palpate the testicle, if some males have an anatomical variation that their scrotal cavity is connected with pelvic cavity through peritoneal canal, this effusion might get inside the scrotum, and palpation will provoke pain in the testicle region. That doesn't happen very often, but it may happen, and you should be aware of that. So, briefly, these are findings which we've recognized during physical examination and anamnestic collection. When we summarize all that we found, we can make a statement that regarding patient's complaints anamnestic data results of clinical examination by systems and organs the summary tells us that all those findings probably, with most probability, can refer to acute appendicitis. So once again, first thing we know, it's passport part, name, age and gender of patient. Then we have the complaints section, main complaints. This part about occurrence of pain, I've made a small mistake, it doesn't go here. This should go to this section. It goes to anamnesis of a current disease. Next, we know additional information about his anamnesis of life. We have the all collected data from physical examination. We've defined certain most crucial symptoms which lead us to a statement that probably this patient might have acute appendicitis. But why is this preliminary diagnosis? It's called preliminary because all those symptoms may refer to some other diseases which can mimic acute appendicitis, or in other way, this patient might have some another disease, but if we misdiagnose it, if we underdiagnose or overdiagnose, we will miss his real disease, which manifested by absolutely the same clinical symptoms. That is where our preliminary diagnosis section ends, and we proceed to differential diagnosis.